All right, I am at clinical, so I just wanted to get some information out on intracranial regulation, impaired cognition, those two concepts. So big concepts really, as well as at the very end, I'll talk a little bit about mobility, okay? But when you think of intracranial regulation and cognition, impaired cognition, either of those two concepts, we really are thinking about the brain and brain activity, the electrical activity or the oxygenation to the brain. So chemicals and enzymes, electrolytes, everything, okay? You have to go back to patho, and it's not even patho, it's part of our, and we look at the cerebral cortex and look at the lobes. What does every lobe do? Frontal lobe is responsible for what? Parietal lobe is responsible for what? Your limbic lobe, the temporal lobe, and that's occipital lobe. So if you understand what it's related to, there's like occipital is vision. Frontal lobe is related to what? Judgment, okay? Then you have to know which one's for speech, all right? And for, what else? Movement, okay? Because when there's a stroke or seizure activity that's in a certain part of the brain, they might have post-seizure, post-stroke, they can have complications, mobility complications. So it sort of ties together. So just remember to look at the intracranial regulation concepts. But if you look at cognitive impairment, what are some forms of cognitive impairment, right? You can have delirium. We can have, what else? Cognitive disorders, right? Important. Learning disability, okay? All these things are types of cognitive impairment, intellectual abilities, focal cognitive disorders. So make sure, I would make a table, assessment of intracranial regulation, and make a table that shows subjective data about the patients, objective data, mental status, neurological status, the stuff we're doing, reflex activities, motor function, sensory function, and then diagnostic stuff. What do we do? Brain, EEGs, cerebral angiography, right? MRIs, CT scans, labs, lumbar puncture. Okay? So look at their subjective, objective, and make a table of diagnostics. Remember, you must understand your Glasgow Coma scale for this exam, and total points are what? 15, right? Remember, you have to be able to look at the eye movement, verbal response, motor responses. As you remember from the last exam, changes in mental statuses can be, it's an RIT. The book even states this in one of the nursing things, one of our little boxes in there, changes in mental status, early warning sign. Review your Glasgow Coma, and I think I might have, if not, I will post something on Blackboard that has this autistic calculator. But sleep deprivation, here's cognition. You guys know that, I know it, right? What are common causes? So look at that. Delirium, delirium, our patients are at risk for delirium with long-term hospital stays, okay? Any condition can end as a result of a delirium, especially the longer they're in the hospital. With delirium, they can be combative, agitated, restless. They can be drowsy, somnolent, or unarousable with delirium. So there's three different types of delirium. So now let's get into seizures. I mean, delirium, there's a little bit on, so with the exam. But with seizures, you're going to look at what is it? You have to know the pathophys behind seizures to understand what's going on. They, what do they result from? They're electrical imbalance, right? It can be, it's like a heart, okay? You have electrical discharge in the heart, and you have an electrical discharge in the brain, right? And it's abnormal in the cerebral cortex. So there's firing, okay? It can happen spontaneously for, for any reason, unknown causes. And then, once you've had a seizure, you're at risk for having more seizures, but you have to figure out why, because something's happened with the baseline. So causes of seizures can be genetic, right? You can have a brain injury, head trauma, TBI, lack of oxygen, hypoxia. My phone's ringing, sorry. GABA, neurotransmitters. Think about the drugs. Blood glucose, right? Hypoglycemia, metabolic imbalances, high fevers. You know, you can see it in peds when those babies get such high fevers. And if it's not treated, it can seize. So the types of seizures, know the difference. Tonic, clonic, stiffening and rigidity of the muscles. That's tonic. Okay. Clonic is jerking of the extremities. All right. Myoclonic is brief jerking, occurs singly or in a group. Okay. And atonic is a sudden loss of muscle tone. Right. Which one is the grand mal we used to call tonic? Okay. So then there's review your types of consciousness. Okay. Look at it because they can have that blackout period, but it happens after a seizure. Okay. Then there's other types that they remain conscious throughout the seizure. So remember, we have the atonic, the hypotonic, the tonic, and the tonic-clonic. Make a table in the book. That's the best way to do that. Or you can make one concept map of all those. What else do we talk about with seizures? Our nursing care, review your nursing care seizures, right? How do you do an assessment with a patient who has seizures or who just had a seizure, post-seizure, right? How do you lie them down? You know, we used to stick tongue blades in their mouths, and we no longer do that. But you can suction. The table in the book says, have a Yonkar suction ready. And you will see at every patient's bedside, look behind their bed, and you're going to see a Yonkar suction. Okay. So when you have status epilepticus, I hate saying that word, epilepticus, it's really a medical emergency. So that brain is not getting control of the seizure. It lasts greater than 5 minutes. It's continuous. There's no recovery. So you need to maintain the airway, right? You might need IV meds. What are your meds? So look up the meds that we give, the primary meds that we give, phenatonin, lorazepam, also known as Ativan, diazepam, those meds, okay? You're going to give a bolus of them to try and break that seizure. I mean, those meds are given for other reasons as well. But if it lasts longer than 10 minutes, it can end up in death. And why do you think that is? Lack of glucose. Most seizures, you know, stop when the glucose is gone. They've utilized it all. Because the brain can't create glucose. Remember that. Let's see. So review epilepsy. Okay, it's going to be a little bit about epilepsy. Nursing care of epilepsy. They talk about padded side rails in the book, and I think in ATI it talks about padded side rails might be contraindicated. It's really based on a hospital protocol. Okay, so you never restrain a patient that's having a seizure. You comfort, you protect them, help protect their airway, help guide their extremities, depending on how they're seizing. Okay. What else do we need to talk about? Review your medications, the common ones for anti-epileptic, so different than your seizure meds, right? Tregatol is one of the big ones, but you have to know the generics. Just a couple of them. Gabapentin's big too. You hear a lot about it. Let's see, phenatonin. So seizures. So know the difference in seizures. Review those 4 different types. Let's do it. Static epilepticus. A little bit about delirium. Excuse me, and you know, some hypoxia, but we'll get into a couple of other things. Let's see how long it takes. Okay. Stroke is one of my favorite topics. It's a perfusion problem, right? It's a brain attack. They call it in the book. It's like a heart attack in the brain or a bleed in the brain. You can have a rupture, aneurysms. Remember that, which I don't think we talked about yet. Yeah, I think it was from pathophys. We talked about aneurysms. But really, a perfusion of stroke is just stroke is when there's a lack of oxygen to the brain for whatever reason, right? It can be a hemorrhagic stroke, which is bleed, hemorrhage, or it can be a thrombolytic or embolic stroke, a clot, right? Caused by atherosclerosis, foreign objects, if you remember from patho, you know, amniotic fluid, air bubbles, fat dislodging, platelet adhesions, cholesterol, right? Thrombotic versus embolic. Embolic is a loss. Let's see what else. Medical emergency, but you know that right now. So you're looking at the fast, right? You always want to ask the family, when did it happen start? And the biggest thing between a facial hemorrhagic and a thrombotic or embolic stroke, the signs and symptoms are very similar. You can't tell the difference, all right? Sometimes with a hemorrhagic stroke, they'll complain of a headache and that's it. And then they bleed, the worst headache of their life, okay? But you have to get it diagnosed because we treat differently. And the most emergent thing that needs to be done diagnostic-wise is a head CT before you do any interventions with anti-platelet medications or blood thinners or blood busters or any of that, because you'll kill patients. Okay, we always get a head CT. Always ABCs first, because if they're having airway, if they cannot maintain their airway, we have to help them with that. Okay. So make sure you look at how we analyze and differentiate them. Okay. And real fast, that's what I was saying. It's facial droop, arm swaying, sensory, and then time. Okay. The time started because time is of the essence with a stroke. Time is of the essence with a heart attack. Let's see, what else do we want to talk about? You must know the difference in hemorrhagic and ischemic strokes. Do not get them mixed up. And TIAs. So what's a TIA? Transient ischemic attack. And it lasts less than an hour. As the signs and symptoms of stroke. Right? They have the facial drooping, they have the swelling. It's often impending of a stroke. So these patients need to get worked up, right? They need to have carotid artery studies. They need to have their cholesterol levels taken. They need to have head CTs to make sure there's adequate flow, right? They'll have an angiogram, excuse me, which is where they squirt dye up into the brain, just like when they do it with the heart. But know your thrombolytics. So, I mean, you don't need to know the thrombolytics, but you're going to give thrombolytics and anticoagulants with the ischemics and atherosclerotic thrombotic strokes. Okay. So your medications. So with it. So what might you think you want to give these patients if they have stroke lights? You don't want to increase their intracranial pressures in the brain, bearing down, so stool softeners, right? Pain, anxiety meds. Okay. Calcium channel blockers typically are given. Medical management is very dependent upon what type of it is. Okay. Let's see what else. The fast is what we want to teach our patients. Speech, S is speech, sorry. Looking at a presentation. And so nursing interventions are your ABCs, medication interventions, evaluations, recognizing cues for stroke. The biggest thing within stroke is recognizing the cues of stroke. That's what we call them, stroke alerts in the hospital. Okay. A lot of care coordination, a lot of treatment, a lot of rapid moving parts. There's protocols, but we'll get into that next semester. Okay. Really, with the drug therapy, the biggest thing you need to understand is which one you would give or wouldn't give. Okay. You wouldn't give a thrombolytic with a hemorrhagic stroke. Because remember, what's going on with the brain? Well, first of all, if you have that clot that's in there, if it's a thrombotic stroke, you have a lack of oxygen disability. If you are having a hemorrhagic stroke, there's a perfusion problem also because it let out, it burst open, either related to what? Hypertension, which is one of the biggest causes, right? Weakening of the vessels in the brain, that chronic hypertension, right? Cerebral hypertension. And eventually one of the vessel walls weakens. But when it bleeds, where's it going to go? You've got a brain, you've got a skull, so it can't bleed out anywhere. So it's just going to continue to bleed until it's smushed the brain tissue. And that's where you have your symptomatology, right? Depending on where the bleed is in the brain, the lobe, temporal lobe, what's going on, what are the symptoms? So with hemorrhages, really with treatment, it resolves. You know, sometimes they can go in and they catch it before it's going to happen. They can put it in a stent up in the brain, in the arteries, cerebral arteries where it's at. Like, let's say they're having TIA. And what else? I'm trying to think off the top of my head. I'll read in the book. And with that's hemorrhagic, and with thrombotic, it's, you know, they're both oxygen, lack of oxygen. They have a lack of hypoxia, and they have problems with, they have symptomatology. So it can resolve, but like I said, hemorrhagic, it resolves. The blood has to be reabsorbed, right? Hopefully it's not too bad that they are left with a lot of bad outcomes, you know, difficulty speaking, walking, whether it's whether it's one side or the other of the brain, okay, increase intracranial pressure. So these patients will often want them with a low CO2 to decrease their intracranial pressure. TIAs, seizures, I'm sorry, TIAs, hemorrhagic and ischemic stroke, nursing implications. So go through all that. Oh my God. All right, I'm going to pause and do a second recording.